Good evening. This evening we're going to be talking about robotic joint replacement and specifically hip replacement. My name is Dr. Suresh Nayak, and I'm a partner in Wellington Orthopaedics and Sports Medicine as well as OrthoCincy. We have a great affiliation with the St. Elizabeth's hospital system, and I work at the NKU office as well as Eastgate and Anderson office. I'm a fellowship-trained orthopedic surgeon. And I'm also, I teach down at the University of Cincinnati in their adult reconstructive division. As far as my education is concerned, I trained here in Cincinnati. I did my fellowship at the Cleveland Clinic Foundation in adult reconstructive hip and knee surgery as well as shoulder surgery. I've been in practice now for 25 years in Cincinnati, primarily with Wellington Orthopaedics, and recently Wellington Orthopaedics and OrthoCincy merged, and now we're one big happy family. So I am really happy to be involved with in the Northern Kentucky space. I am board certified in orthopedic surgery as well as in sports medicine. So my practice has evolved into one taking care of patients. The general division is called adult reconstructive and joint replacement surgery. We have subspecialty training in hip replacement, partial and total knee replacement, shoulder surgery. Over the last 15 years, we've been doing more and more robotic surgery, and we've just completed our 2,000th robotic surgery. We've done about 7,500 computer-navigated surgeries. We also do a lot of sports medicine, and nowadays, especially with the pandemic and opioid-sparing surgery, we've focused into how to do these surgeries effectively as an outpatient, as well as with minimally invasive techniques. So today, my charge is to talk about hip replacement surgery and what the advances are in this traditionally fairly painful surgery and how to recover from it faster. So as we talk about normal hip anatomy, the hip is made up of a ball and socket joint. Technically it's called the femoral head and the acetabulum, big long names. We'll just call it the cup and the ball. Between the cup and the ball, there's a very specialized tissue called cartilage. Cartilage is a very specialized tissue that once damaged is very difficult to heal. If you think about other tissues that get damaged, whether it be skin, bone, tendon, most of these things can heal, but with cartilage, it really does not heal very well after the teenage years. So once damaged, what can happen is the pain, the stiffness can set in, and really what's happening here is that the cartilage is damaged and the bones actually start to rub against each other, causing significant amount of pain, disability, and the quality of life is significantly affected. What that looks like on an x-ray is on the left-hand side you can see a normal space between the ball and socket joint, and on the right the space is gone. This is a patient with fairly significant arthritis. The causes of arthritis are numerous. Primarily it's osteoarthritis, where it's just wear and tear. Other people can get inflammatory arthritis, rheumatoid arthritis. There's 100 different types of inflammatory arthritis where the immune system actually attacks the joint and the cartilage and can end up with significant damage to the cartilage. Trauma can do it as well, car accidents, falls. There's a condition called avascular necrosis, where the blood supply to the ball is compromised, and then subsequently the ball, it gets damaged and arthritis sets in. Infection can damage the cartilage. Certain childhood diseases can also cause problems with the native hip joint. Eventually, what the common pathway is cartilage gets damaged, the range of motion decreases, pain increases, people start to limp, and really then seek the care of their primary care provider or a subspecialist like myself. So what do we do with patients that present with hip arthritis? Well, we don't always go to surgery. First of all, we spend a lot of time trying to do non-surgical options such as weight loss, Medications, injections in certain instances really do help. Bracing, physical therapy. If you can't exercise on land, walking, bicycling, everything's painful. Aquatic therapy is really key, and try to keep moving, keep your joints moving, and trying to keep muscle tone, etc. Very good. So when those things fail, then we start looking at surgical intervention. And a surgery for this problem is called a hip replacement. So a hip replacement is a fairly invasive operation. It's been around for probably 40 or 50 years. First devised in England by a doctor named Charnley. And there was all kinds of different operations and things to put in between the ball and socket joint to try to relieve pain. It's been refined over the last 40 or 50 years, and I dare say it's almost routine now, but it can be. Basically, it involves taking off the ball of the patient's hip and putting in an artificial ball and socket joint. This has been proven over the last 40 or 50 years to be a very successful operation in relieving pain and restoring function. We can get patients, within an hour surgery and get them their life back within, several weeks. So this is kind of the operation that we use to relieve pain and restore function. What are the different ways we can put it in? The approaches to hip replacement have traditionally been a posterior approach where the muscles are incised, sometimes have to be detached from the bone to be able to get at the joint replacement itself. Then we went to a lateral approach, and then most recently over the last 10 years it's been an anterior approach, which is a muscle sparing approach. We separate the muscles and we don't actually cut through them. That way the recovery is enhanced, there's a lot less pain, and we can have a quicker recovery in this part. Unfortunately, it's a fairly, the learning curve on how to do an anterior approach is fairly steep. We need specialized equipment, and our colleagues at St. Elizabeth's have this equipment and have invested a lot of time and money in trying to train personnel, as well as invest in the special tables, etc., to be able to do this operation very routinely now. So over the last 10 or 15 years, the anterior approach has been our kind of go-to operation or approach to put in the hip properly. So if it's been such a successful operation and we can now do a lot of things to alleviate pain, so why do we have to keep revisiting this? It seems like a problem that's been solved, but if you really think about, and you've heard about people that have had problems with hip replacement, and we call it manual hip replacement, meaning that the doctor kind of lines things up with their own experience and kind of just looking at the bone and kind of, we dare say an old-fashioned technique, but the manual technique has been around forever, and we basically eyeball things. The things that can happen wrong are that the implants can be malpositioned, the sizes could be wrong, instability can happen where the hip may dislocate. We frequently hear about people that have had one leg longer or shorter than the other. And ultimately, we want that hip replacement to last your lifetime, 20, 30 years. And it's a very tall order to do one surgery for a half an hour to an hour and get that hip to last forever. So these are the complications that we've been running into with the manual or the approach that's been taken over the last 40 or 50 years. And so to just several examples in my own practice that have come about in the last few months to years. The next slide looks at a dislocation where the ball actually pops out of the socket. This has been, depending on which approach, the posterior approach, about 5% of hips may dislocate or have some instability. Anterior approach is not as much. If you look at the next slide, this is an example on the right-hand side where the cup is put in very vertical. This patient has been dislocating on the right now for probably the last 4 or 5 years. The left one was done with our robotic technique and has been very stable, and the patient is looking at having a revision now on the right side to properly align the components. Next slide shows a very tragic patient who saw me immediately after her surgeon, another surgeon did the surgery. If you look very carefully, the cup is actually inside the pelvis. The surgeon actually took away so much bone that now the cup, as soon as she put weight on it, the cup actually went into her pelvis. And this is a major reconstructive endeavor where we have to reconstitute bone. We have to have a general surgeon go inside the pelvis and retrieve the prosthesis for us. So it's a very devastating complication that I dare say may have been prevented with some advanced technology. The next example is of a patient that had this implant put in about 8 years ago and was put in with the cup in a different angle. So every time the patient rotated their leg, the femoral component banged against the acetabular, the cup component, and actually broke the femoral component's metal in half. And recently, as early as last week, I had to go in and take out the old, reorient the cup so that the patient wouldn't be doing that. And the redo operations are very long, the recovery is a lot longer, and a lot more complications that can happen. So the question is, how can we do this better, and how do we use technology to try to help us, help you get on your feet quicker, reduce complications, and get your life back? So what the implant manufacturers and Stryker, Mako have afforded us over the last 10 to 15 years is robotic technology. The robot is basically a robotic arm that is non-autonomous, meaning that the robot can't do the surgery by itself. It still needs a surgeon to do the surgery. So I still have to be there, and we can look at every individual. The robot is actually wheeled into the operating room as the patient is anesthetized. There is a Mako product specialist who actually helps us run the robot through the Mako guidance cart, and there's a high definition camera and stand that we use to look at every patient's leg and pelvis in space in real time to make sure that we're doing the surgery correctly every single time. So preoperatively, we do a CT scan of the patient and actually look at a three-dimensional model of every patient. We actually put in implants, virtual implants, into that model. We can actually change the position of the implants, and with our newest technology, with the 3D imaging, we can actually virtually move the hip around and make sure that the patients aren't dislocating beforehand. And if they do dislocate on our three-dimensional model, we actually change the positions around in real time to make sure that doesn't happen. So this is called virtual range of motion, and in this slide you can see where the femur actually impinges on the cup, and in that situation we can change the position of the cup or add a little bit of length so that doesn't happen. And again, this is before surgery. This is before you're at home eating your last supper before you come in for surgery, and we're doing this before you come in so that we know exactly where to put your implants. So this is a little video that we can play. It shows the Mako robot. Again, there's various different types of robots. We have one for the hip, we have one for the knee, and also partial knee. And again, what we try to do is a three-dimensional image. The CT scan is done preoperatively. It gives us a three-dimensional model of normal anatomy. We can actually work on that three-dimensional anatomy preoperatively, put the implants in, kind of change the position. During surgery, there's a process we do by patient-specific planning, but also intraoperative. We actually tell the robot where the bone is in space. We map out the surface of the bone and then preoperatively plan exactly how much bone to resect. Once that's done, the femoral component can be mapped out within a millimeter degree to our plan. Again, we can check things in surgery to make sure that we have hit our target within a millimeter and a degree. Similarly, on the cup side or the acetabular side, we tell the robot exactly where the anatomy, the patient's anatomy is. Once that's correlated with our plan, the robotic arm is brought in and it knows what our plan was, and this is basically a computer-aided design manufacture kind of a philosophy where when we hit the trigger, and again, I'm still hitting the trigger, we resect the exact amount of bone that we preoperatively wanted to. Then the robotic arm is brought back into the field and we can implant the cup in exactly the amount of, we call it anteversion and inclination within a millimeter degree, so that we're not resecting, we're not pushing that cup into the pelvis like the previous example. Then we put everything in the cup and the socket in place. We do a virtual range of motion, an actual range of motion. We can check leg length, offset, make sure that we hit our plan within a millimeter degree so that we can get you up and walking that day, and again, with a minimally invasive approach, as well as the robotic techniques, hitting our plan within the millimeter degree that we really want to make sure that none of those complications really happen. So again, with the Mako robot, with our advanced techniques of approach, muscle sparing approach, with the newer techniques of nerve blocks, decreasing the amount of narcotics that we use, it ends up with less bone loss and less soft tissue damage, less need for opioids. Minimally invasive surgery lends to less hospital stay, and frequently about 2/3 of our patients now are going home the same day. We have less need for inpatient physical therapy, and again, significantly less post-operative pain. Again, these techniques can be used for hip replacements, for knee replacements, as well as for partial knee replacements. All right, now you're going to meet Mary, who is one of our occupational therapists, who's going to talk to you about how to recover from all these and get back to your life.
Hello, I'm Mary Daugherty. I'm an occupational therapist and I am a manager of rehabilitation services at St. Elizabeth Dearborn. Today I'm going to talk to you a little bit about occupational therapy services after you have a hip surgery. To start, I'm going to tell you a little bit about the different types of therapy that you may receive after having hip surgery. You may receive physical therapy and/or occupational therapy. In physical therapy, typically the goals are to improve your muscle strength, your range of motion, your balance, your ability to walk, get up and down the stairs, and they also help to reduce pain. But for occupational therapy, our goals are to make our patients as safe and independent as possible with their everyday activities. So that might include bathing, dressing, toileting, grooming, all of the everyday activities that you may do. Please keep in mind, though, that your physician orders will guide what type of therapy you may receive during your hospital stay or even after your hospital stay. Your physician will also provide specific instructions to you based upon the specific type of surgical procedure that he or she performs. Please keep in mind that all therapy services require an order from your physician to initiate care. So today I want to just kind of briefly talk a little bit about two different types of approaches to surgery that your physician may perform. One approach is the posterior approach. That's when you have an incision that's more along the back of your thigh. If you have the posterior approach hip surgery, then you'll have rules to follow, including don't bending your hip more than 90 degrees, don't cross your legs, and don't allow your legs to turn inward. So there's a few hints on this picture. Things to keep in mind is that you don't want to sit on a low chair or a low commode. You don't want to reach anything that's below your knee level, whether you're sitting or you're standing, and you don't want to sit in a low bathtub. Other things to consider is that you don't want to cross your ankles while you're in bed or cross your ankles while you're seated in a chair. In order to avoid turning your legs inward, sleep on your back with a pillow in between your knees, and don't twist your body while you're standing or laying down. If you have an anterior approach hip surgery, that's when you have the incision along the front side of your thigh. With that type of surgery, you don't want to extend your leg behind you while you're dressing, bathing, or backing up to the commode. Do not rotate your operated leg outward, and do not cross the midline of your body with the operated leg while putting on your socks or your shoes. While preparing this talk, I tried to keep in mind that every patient has different needs. For example, some of my patients return home alone after surgery. Other patients have intermittent support where family members come in and out. Some patients have care that is around the clock. Some of the patients may have precautions, and some of the patients may not have precautions. So first, I'd like to give you some hints on lower body dressing. The device that you see in the picture is called a reacher. Some patients call it a grabber, but you can use this for many functions. If you use this for lower body dressing, keep in mind that you want to dress your surgical side first. Pinch the side of the pants on the surgical side, drop it down to the floor, and then pull up with your reacher. That will help you avoid bending over, which will reduce the pain in your surgical hip. Next, we'll talk about shoes. There's a lot of different types of adaptations for shoes. I've pictured here a couple of different styles of Skechers shoes because, as you can see, there's no laces to tie. These shoes actually have elastic cords that allow you to slide your foot in and out of the shoe with avoiding having to tie the shoe. Next, you'll see some elastic laces that can be placed in your tennis shoes as well. These are graded in size so that closer to your toes is more narrow, closer to your ankle is more wide, and so it makes it easier for you to slide your foot inside of the shoe. You can use other devices, including a long-handled shoe horn or a dress easy that's pictured here, to help you slide your foot into the shoe. Again, this helps you to avoid bending over, therefore avoiding pain in that hip. This next device is called a foot funnel. So it has a plastic molded area with a string. So you hold on to the string and put the device inside of the shoe and then slide your foot into the shoe. After your foot is all the way in the shoe, you can pull out on the strings and it leaves your foot in the shoe. The advantage of this product is then you aren't pushing down on the heel of your shoe and breaking down your shoe after repeated use. So next we'll talk a little bit about socks. The device that you see here is called a sock aid, and it's pretty cool. You put your sock over the edge of the sock aid, pull it all the way onto the device, drop the device to the floor while you're holding onto the handles, and then start to pull up on the handles. The sock will then stay on your foot. It is pretty nice because, again, you don't have to bend over to use this device. In order to take your socks off, you can use a device like this, a dress easy, and you can use a little hook to push the socks off. You also saw the reacher earlier that was used to put on your pants. You can also use that reacher to help take off your socks. So now let's talk a little bit about toileting. What you're seeing in this picture is a bedside commode. Some people call it a 3-in-1 commode because it has 3 functions. You can sit it next to your bed at night, you could set it over top of your toilet to become a raised toilet seat, or you could put it in a shower stall to become a shower chair. In this picture, you'll be able to see the bedside commode over top of the toilet as the raised toilet seat. If you look to the picture to the right, you'll see that it comes with what I call the bucket without the bottom. So you place that inside of the bedside commode while placing the bedside commode over the toilet. That way, you don't have any splatter. The advantage of having the bedside commode over top of the toilet is that you can adjust the height up and down to your comfort, and you have the arms to help you with the transition from sit to stand. The picture on the left shows a raised toilet seat that is placed on top of the commode, and then it has a knob to tighten the raised toilet seat onto the commode. I will say though, my patients complain that this style of raised toilet seat does not provide enough room for hygiene purposes. With the raised toilet seat that's pictured on the right, it is actually adhered to the commode. If you think about the lid of the commode, how it has a screw that fits the lid to the toilet, These come with an extra long screw that helps mount the raised toilet seat onto the commode. That gives you a little bit better fit than the device that's actually pictured on the left. The other advantage is that you actually use your toilet seat over top of that raised toilet seat. Keep in mind though that if you are going to purchase a raised toilet seat to go over top of your commode, you want to make sure that you know the style of your commode. Some commodes are more round while others are more elongated. So you want to make sure that the raised toilet seat fits. Next, I want to talk a little bit about bathing. So let's first talk about a shower stall transfer. You can purchase a shower chair like the one that's on the left. If you are to purchase one, I do suggest one that has arms that will help you to transition from sit to stand. You can also use that bedside commode in the shower stall as we discussed earlier. In this picture, you will see the therapist backing up to the shower stall and putting the good leg in first. You'll hear this rule: up with the good and down with the bad. So you're going up into the shower with the good leg, and then you'll step into the shower with the surgery leg. Use that walker as your support. That will help you for safety to avoid reaching onto things that you shouldn't hold on to, like the shower curtain or the soap dish or the towel rack. Next, if you're going to bathe in a bathtub, consider using an extended tub bench. As pictured here, you'll see 2 legs inside of the tub and 2 legs outside of the tub. When you back up to it, you'll sit down and then slide your legs over into the tub and then scoot all the way in. In these pictures, you'll actually see how you can modify your shower curtain to keep water inside of the bathtub if you use the extended tub bench. If you want to modify your own current shower curtain, close the shower curtain and use a pair of scissors to make 2 slits in the same places where the legs of the shower bench are. That way you can stuff the curtain into the bathtub and along the slits in the extended tub bench. Anytime that you're going to sit down to take a shower, I do recommend the use of a handheld shower head. I like the kind that has the pause feature or the ability to turn the pressure on and off at the handle. That way, when you set it down to wash your body, you're not spraying water everywhere. As you'll see on the picture at the right, you can also purchase a suction cup shower head holder so that you can move it anywhere in your shower, which makes it a little bit easier to reach. Other things that might help you with bathing is the use of a long-handled bath sponge. This one in particular here, you can bend, and so it makes it a little bit easier to reach the bottom of your feet. All right, so here's some other home safety considerations to think about before surgery. You want to place those frequently used items in easy to reach locations and avoid those low cabinets or the drawers, anything that's below your knee level. If it is below the knee level, then consider using your reacher to pick up those items. Remove those throw rugs around your house, but I feel like it's okay to use a rubber-backed mat when you're exiting the shower. Make sure your furniture is arranged that you can take your walker freely throughout your home. Sometimes just moving a piece of furniture an inch or 2 can make it a whole lot easier to get around. Keep your extension cords out of the pathways throughout your home as well. You can adapt your seats with pillows so that while you're sitting, your knees are at level with or below your hips. You can even consider taking an extra couch cushion and placing that under your bottom to raise your height up as well. Use a walker bag or basket to transport items throughout your home. You could also use an apron, or the guys may have nail aprons to be able to have pockets. You can place that on your body or place that on front of your walker to transport items. Use containers that have lids if you're going to transport liquids. Use paper plates, plastic cups, plastic utensils. That way you don't have as many dishes to wash and it saves time and energy. Prepare your meals in advance and freeze some to make it a little bit easier as well. Make sure your pathways are clear from your pets and pet toys to reduce your risk of falls. And again, making sure that you have a well-lit path from your bedroom to your bathroom can avoid a fall at night. So here's a few tips to help you during your hospital stay. Please don't try to get out of bed by yourself. Call Don't fall. We're here to help you. Consider taking your pain medicine before your therapy sessions and before your pain gets out of control. Bring comfortable clothing and secure shoes to the hospital. Avoid flip-flops or shoes that are too loose on your feet. And consider having a partner in care, someone who can stay with you when you go home until you're able to function more independently. When you leave the hospital, your physician may order home health care, and that's when a nurse or a therapist comes to your home to guide you during your recovery. Your physician may order some outpatient physical therapy for continued exercise, strengthening, and walking. Your physician may not order continued therapy upon discharge. And whatever services that you need when you leave the hospital, a care coordinator will be available to help you make those arrangements. If you have additional questions, feel free to speak to your physician. Your physician will guide your care and determine what type of surgery best fits your individual needs. I've included the list for the St. Elizabeth Total Joint Center that they can help answer questions as well. Additional information is also available on our St. Elizabeth website. They do have a HIP packet that's designed to answer additional questions. Thank you for joining us this evening. Please stay tuned and we'll have a question and answer session together with Dr. Nayak.